Now I invite Dr. Sonu to introduce our last speaker of the North Zone Talent Search. Sonu, over to you.
So Dr. Veer Singh is a young, dynamic vitreoretinal surgeon working at the SP Dr. Sohan Singh Eye Hospital, Amritsar, Punjab. He completed his surgical vitreoretina fellowship at the Shankara Nethralaya, Chennai. He has cleared his FICO Retina UK. He has authored many publications and has multiple presentations. And his major area of interest is vitreoretina and uvea. The lead judges for this presentation would be Dr. Ayachit, and I think we can request Dr. Prashant to be with us, and
Dr. Prashant and Dr. Kumar also.
And Dr. Kumar as well. Yeah. So all to you, Veer, and you can start sharing your screen now.
So Sonu, just to mention, Veer is a Belgaum alumni. He's an alumni from Jain Medical College, my parent institute. So I always feel proud to mention my college name whenever any alumni member is presenting in this.
Yeah. So, but I know that you are not judging.
I'm not judging. That's why it's okay. And nobody is there from Belgaum, so don't worry.
Thank you, sir. Yeah. I'd like to thank AIOS and POS for giving me this opportunity. I'm going to be showing my mini PVD technique, and it's used in managing challenging PDR cases. So there's no financial interest, but I have a disclaimer that this video won the runner-up award at IRSI Awards this year. In diabetic TRD vitrectomy, the difficulty level all depends on whether there's a PVD or not. In case there is a PVD, the membranes are lifted up like in these two pictures, and that there's a clear dissection plane. There's plenty of space to work with. So case is easy. In case there isn't, so there's no place to work, the membranes are flat, and it's a very difficult case. So in these flat membrane TRDs, one always tries to locate a membrane edge, lift it up, try to get into the correct plane, and then work from there. But the problem is a lot of these cases are vitroschisis, and you end up in the false plane. This is where my mini PVD technique comes in handy. I never search for a membrane edge. I go straight to the disc and lift up the hyalod from there just by a millimeter or two. This gives me a small PVD around the disc in that green zone and creating space between the retina and the membrane. Opening that gets me right in the correct plane of the second membrane, making surgery very fast, very easy, and alleviates the need of switching on to bimanual surgery ever. There's never a need to search for a membrane edge. 10K bevel cutter, when you combine it with this, it's got a unique shape, helps you work safer, closer, and along the retinal contour. So there are two cases that I'd like to show videos of demonstrating this technique. In the first case, this is an advanced PDR case. I don't look anywhere, just go straight with my forceps to the disc and just lift up the hyalod a little bit. And you see that arrow, PVD is extended just till there. And on the nasal side, just a PVD, just to get an opening to create an edge rather than finding an edge. And then I engage my cutter there, and then I start from there. If you notice, the membranes come so easily because I'm in the correct plane. I don't have to make any effort, and it's pretty much like a cakewalk. Everything just jumps to my cutter. And in fact, even this adherent membrane, there's no bleeding because I'm in the correct membrane. And all I'm doing is just extending that edge of that mini PVD that I created. On the nasal side, they're usually very strongly adherent. So you have to do it again. And just freshen up that mini PVD, get that edge created artificially, and you see how the retina just folds back into the cutter, and it's just cakewalk from there. And that same edge you extend into the periphery, get those membranes up there into the cutter, and not much to be done further on. And then that's the last part of the membrane, which just comes by a fold back delamination. In fact, this patient did very well and got 612 vision at 8 weeks. In case 2 is a similar case. Again, this is a flat membrane, just clearing up the hemorrhage. In this, I use a cutter. At a very low suction, I just try to induce a PVD. And you see that blood that starts gushing. That tells me that the PVD has been created and there's been an opening. And I move on from there, extend the PVD just by 1 or 2 disc diameter, just 1.5 disc diameter. Again, doing the same thing nasally, not causing traction on those adherents, the strongly adherent points. And you see how beautifully this beveled cutter, the shape, it goes right into those spaces and helps me work so close to the retina without damaging the retina. Again, on the nasal side, because of the adherence, I freshen up that mini PVD. And when I have that edge, it's just, again, so easy to extend that into the periphery. And then superiorly, again, that same edge that I created initially, I'm working on that, mechanically dissecting. And you see that bevel cutter, that shape is so amazing that you can just sit on the retina and cut those membranes. I'm literally touching the retina, but nothing's happening to the retina, and all the membranes are coming. In fact, that's the last part of the membrane. And you see there's a bleed here. Now you see a bleed. You can use the same tip to give mechanical pressure and control the bleeding. The shape is such that it aligns so well to the contour of the retina. Again, extending that same edge further, no need to find a new edge. And that's the last part of the membrane, which comes off very easily, lifting that last part of hyaloid and finishing up with the ILM peeling and endolaser. And that's how the case looks in the end. So these are some of the cases managed by this technique. So I'd just like to conclude by saying that, using this technique really eliminates the need for a bimanual surgery, and you have very fast and very efficient surgery with this technique. Thank you.
Thank you, Veer, for that wonderful presentation. I think more than the cutter, it is the man behind the machine. And congratulations.
Thank you, sir.
So can we have the lead judges?
Nice presentation, Veer. That was a good display of your deftness. But I must say that no two cases are similar when it comes to diabetic vitrectomy. So you can't say that this will work for all cases. This particular technique will work for all cases. Maybe for flat membranes on the disc and spreading beyond the disc are the cases which will benefit by this technique. In fact, I belong to the generation where we graduated from the 20 gauge era. And during the 20 gauge era, we didn't have these micro instruments, and we used to work from the disc peripherally. It was always inside out. We used to call it inside out technique, where we used to tackle the disc membranes first and then go towards the periphery, because we believed that the posterior retina is thickest. And as you go to the periphery, the retina becomes thin, and that is where you should probably stop. So, and one more thing is the problem comes in diabetic vitrectomy usually at the arcades. You can get away with the membranes easily. You can do the membrane surgery at the disc in the periphery as well. But at along the arcades where the adhesions are very strong, that is where the problem comes, and that is where you have to look for the correct plane. And if you fail, you probably have to resort to bimanual surgery. I think you got away very well with this without any complications. But I think the bottom line of what I'm trying to say is that no one technique fits all. No one technique suits all diabetic vitrectomies. Prashant and Kumar.
Yeah, exactly. That's what I would echo my sentiments here. Same. Yeah. The thing is, inside out or outside in. Inside out, we used to do previously because we had smaller viewing angles, field of view. And so we prefer to move from disc towards the periphery with the concept that the central part of the retina is more thicker. But now with the wide angle viewing system, where you can have a panoramic view of the whole retinal architecture, and in fact, retinal and interrelation between membranes and retina are better seen in this. So many times you will realize, Veer, that when you're seeing with a 90-degree view, you can actually, you go from periphery, induce PVD in the periphery and come centrally, it becomes more easier. What I observed in your cases where all of them were 9 PDRs, predominantly fibrotic type of membranes, and these cases otherwise also do well, be whatever technique you use. And yes, 70% of them can be managed by this. But if you have an associated, what I should say, atrophic type of tractional detachments associated with it, bimanual still has a role. Otherwise, you will end up, in spite of using a 10K cutter, creating a nitrogenic breaks. That's what I feel.
So, sir, can I make a comment?
Yeah, please.
So, sir, like sir asked, this technique, especially I used to, when I started off, I used to face a lot of difficulty in these flat membranes. So this specifically, I found it very useful just in that space, those flat membranes. And yes, of course, bimanual, you can never replace it. But, when creating that space really has, earlier I used to do a lot of bimanual surgery. On the contrary, ever since I started doing this, it has gone on. I'm just able to manage with, unimanually with this.
I think you rightly said, instead of finding the plane, you have to create the plane. That holds very well for this particular type of scenario. Finding the plane for flat membranes, by picking it up and then sort of inducing a PVD, as it were, not for the cortical vitreous, but for the membranes. But you have to be very careful, watching the retina all the time, looking for traction on the vessels, which will cause bleeding, sometimes uncontrollable, and sometimes breaks, which are quite posterior and big, and that is what ends up, a lot of problems. So you should.
my fear most of the time. But most of these cases, I end up using pre-operative anti-VEGF, so that has really worked.
Correct.
Veer?
I would just say that, this is it's a great, webinars are happening all the time, but it's a great initiative to bring out, the hidden talents in all the different zones, and it's a pan-India program. So I think that's very great about that.